This kind of a review. So you see here that we went over this, that blood is about 55% plasma and 45% formed elements. We went over plasma, and then we're going to go over these formed elements. Actually, we went over red blood cells, erythrocytes, and then we're going to go over white blood cells and platelets, and that will pretty much end the chapter. So again, these are the plasma proteins. You should know them. It's a possible test question, and I put these up on the board in class. That was just showing you red blood cells. There's little platelets. They're like pieces of cells. Red blood cells are nice and round. They're called biconcave. None of that is, that's just kind of FYI. Oh, and then here's some white blood cells like here and there. And then I was saying that before you have a red blood cell, which has no nucleus, you have like a precursor, which was an erythroblast or pro-erythroblast. And that was what erythropoietin did. It's a hormone that increases erythroblast, and then that is going to ultimately cause the increase in erythrocytes. And then we see the same word here, poietin. So thrombopoietin, meaning something that increases the amount of platelets. Right, so platelets are only pieces of a cell. Platelets used to be megakaryocytes, and then they fractured into a bunch of small cells. They're not even cells, they're just pieces of a cell anyway. But that word thrombo meaning platelets, right? And then you see here, these are all white blood cells. And there's actually 5 different kinds. They've kind of split it into 6. But we'll go over this on probably the next slide, or the next one I'm going to talk about. This is a review. That's a review. I wrote all that on the board, and there's a separate video with that. Hold on a second. All right. That there's no point in talking about this. This is kind of where we left. Well, okay, I'll go over it really quick. I mean, we left off with this. We talked about this, and I have a separate video that I already posted with this, right? You know that there's 3 parts of red blood cells there, and it's listed right here. There's the globin, which is a protein. Then there's heme, which is iron. Well, actually, heme is, there's an iron portion and there's a pigment portion. So they've kind of split it up into protein, iron, pigment. If we follow the protein, it just gets recycled. So it's just right, I've circled it right here. Right, it just gets, globin gets broken down into amino acids, and then you just reuse it to make other proteins. With the iron, I was telling you that the iron gets picked up by transferrin, and that Fe, that's the symbol for iron. So they're just saying that iron gets picked up by transferrin. You store it as another protein called ferritin, and then transferrin picks it up again and takes it to the red bone marrow. Because remember, red bone marrow is where red blood cells are made. Then the part that was the most difficult because of the words were the pigments. Then we talked about biliverdin. It gets degraded into bilirubin. And then up here, I'm telling you that bilirubin it's just one example of what bilirubin is used for. It could mean hemolysis, like, abnormal breaking down of red blood cells. We expect red blood cells to be broken down after like 4 months or so, right? But we don't expect, an abnormal level of them to be broken down. Bilirubin becomes urobilinogen. It degrades, it gets broken down further into urobilinogen, and then the urobilinogen goes, either it's going to stay in the intestine, and in that case it becomes stercobilin, and they've kind of color coded all of these, right? So stercobilin's kind of like brown, that colors your feces, or some of this urobilinogen is going to head to the kidneys. Then in that case it becomes urobilin. That's going to color the urine. It's got like a yellow color to it. And that's the hardest part of the chapter. That might make it a lot easier. This slide might be easier to deal with than that slide. But we talked about all of this. So this is the new stuff, white blood cells. White blood cells do have a nucleus, unlike red blood cells. We looked at 2 of them in lab. Maybe not all of you, we were kind of not organized, but the 2 that we were seeing were neutrophils and lymphocytes. Here they wrote small lymphocyte. It's a lymphocyte, right? So white blood cells can tell you things about what's going on. If you have a high level, it could mean one thing. If you have a low level, it could mean something else. So there's 5 different types of white blood cells. So, and they're all listed here. Eosinophil, basophil, neutrophil, lymphocytes, monocytes. Don't worry about granular and agranular anymore. It used to be when you looked at these things in a microscope, they would look grainy or not grainy. And that's why we call them granular or agranular. I don't think anyone really cares about that. So anyway, you just put it in a machine, right? And the machine does it all. Like back even in early 90s, we were still putting drops of blood on like this slide with like a grid pattern called a hemocytometer, and we would have to count. We'd have to pick like boxes, like grids under the microscope, and we'd have to count how many of each type of white blood cells in them, and then we would estimate. So it's kind of, I mean, thank God we don't have to do that. So usually within a deciliter of blood, you have about 500 white blood cells. I'm sorry, 5,000 to 10,000. That's like a normal level. Right? It's possible to have not enough white blood cells. In that case, we call it a leukopenia. So PENIA is going to tell you like insufficient, right? It's like not enough. It could also refer to something like muscle, right? So we would call someone that's like without a lot of muscle, that would be like a sarcopenia, right? So that PENIA means like not enough, right? So leukopenia, leuco meaning white, and then too many white blood cells, leukocytosis. Here in black, I just wrote what the high levels meant. I didn't put the low levels. This is just giving you an idea, and I've already got it marked here. So these names come from like the way they stain. So it's like the stains that they use for it. Like there's a stain called eosin, EOSIN, right? So these types of white blood cells, they like this particular stain. That's where the names all came from. So it doesn't really mean anything. Eosinophils are high in parasitic infections. So like something like maybe you have like nematode worms, like that kind of infection, or just something like that. When you've got parasites in you, we tend to not have that. You're not going to really find a lot of eosinophils. It could mean other things, like eosinophils are related to like certain allergies and stuff like that. But I can't put everything. I just put one of them, like the main things, right? So eosinophils are high with tend to be high in parasitic infections. Basophils tend to be high with certain types of cancers or low thyroid levels. The two that you're going to see the most often are neutrophil, which is high in bacterial, lymphocyte, high in viral. Perhaps that's a way, like if you have pneumonia, for example, and you would know pneumonia because you would hear you would hear the gurgling in the lower part of the lungs. So if you hear fluid like in the lower part of the lungs, but not the higher lung fields, it could be pneumonia. Then the question is it going to be bacterial or viral pneumonia? Because one you could treat and one you cannot treat. So what you can do is get like a culture and you could send it off to lab and they can tell you, but the labs aren't super fast at hospitals. They'll do it though. And but now they've got tests that will do it pretty quick. It's really kind of a new era, right? But I would say 10 years ago, they could still look at they would do a CBC and they would still look at your white blood cells. So is it high bacterial or high neutrophil or high lymphocyte? And that would give them a clue as if, is this bacterial? Should I prescribe antibiotics or should I hold off? And then monocytes, fungal infections, and tuberculosis. Tuberculosis is actually a bacteria, but for some reason it jacks up monocytes. And they kind of look like this. Eosinophils are kind of orange, reddish, and monocytes tend to look like the old style telephones. That's their nucleus. When you look in lab, when you look at neutrophils, I was saying sometimes, they look like they have more than one nucleus in them, but you see they're like joined, like right here. They're joined. It looks like many, especially when we look in the microscope, but it's just one. Like this one looks like there's two, right? This eosinophil looks like two, but it's really connected. So what do you need to know from this? You need to know the difference between leukocytosis and leukopenia. And then I'd like you to know the 5 white blood cells. What are they? What are their names? And what would high levels of them indicate? So that's it for white blood cells. When we get to the chapter on the immune system, we are going to focus on lymphocytes because there's different lymphocytes are going to become cells that are called T cells and B cells. So we'll get to that, but that's a few chapters. That's a few chapters ahead, right? So when we visit the chapter on the immune system, we will revisit lymphocytes in particular because they're kind of different out of all of the white blood cells. They're kind of different. So these are the 5 types of leukocytes. I don't care about granular. I don't care about agranular. I got a lot of crap written here. So let's talk about this. So talked about red blood cells, talked about white blood cells. And now we're going to discuss platelets. So there's 2 different types of reactions that you can have for hemostasis, for slowing down blood flow, right? If you get let's say if you just draw blood from your you prick your finger and it bleeds like a drop, right? That's a platelet plug, right? A lot of that stuff, the vast majority of little cuts and stuff you get, those are platelets, right? So a platelet is a less serious way to stop blood loss. But a serious way of stopping blood loss would be a clot, coagulation. But your body's not going to throw clots for like the small stuff, right? So first we're going to talk about platelets and how your body's making platelets. And then second, we're going to discuss coagulation. So I circled here, and I don't really care about it. I circled platelet adhesion, platelet release reaction, platelet aggregation. I don't know why I did that, honestly. It was a while ago. Am I breaking up like you are?
Yes.
I am breaking up.
Well, it's probably on her phone. I mean, I was hearing you very clear. She was breaking up.
I hear you clearly.
Dun, 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 dun.
It's me. Okay, let me see.
Yeah,
Is that better?
Yeah.
I can hear now.
Okay.
Let's who can, I'm gonna put stuff in the chat. I want to see who can like not hear me. Well, put in the chat if you can't hear me. It could be mine. It could be mine. But some of you have said that so far, like I've been okay. There haven't been. Has there been like breaks in me talking?
No.
No, you've been sounding really clear. This is the best, actually.
Yeah, because I'm at a rental property. I'm getting that high-priced rental Wi-Fi and not my cheap-ass home Wi-Fi. Exactly why. And I'm not in Louisiana, so things work.
Oh, yeah.
I feel like when I'm in another state, I'm like, damn, everything's like, why are the roads working so much better? It's like no potholes.
Yeah, everything's better outside of Louisiana.
It's a little depressing. It's like, why, there's no rot. None of the houses are like tilted or cracks in the brick. I just feel like everything's going okay. The food sucks everywhere.
Of course.
My wife, she just like, every time she's like, I'm really disappointed. Yeah, you're in Maryland. You're in Florida. What did you think? What did you expect? You can't go anywhere in the US for the food. You don't go travel around. I really like the food in DC. Oh, no. And it's not how it works.
No, everybody food sucks, like literally. That's why we're probably the top obesity.
Although Mississippi always tries to like race us to the bottom of everything. It's always us and them. All right. So I'm gonna blame the internet on whoever's not hearing me. It's not me, it's you. There. Finally, I get to say that. Usually it's the opposite. All right, I'm gonna go back to the lecture. So don't concentrate on the names of it. I don't really care about that. I just kind of want you to know what's going on here. So see, like right here on that top slide, they're saying here college fibers and damaged endothelium. This is the blood vessel, and this is the lining of the blood vessel, these like yellowish cells. And so, if you remember, the lining of anything is called epithelial tissue. The lining of your throat, the lining of your mouth, the stomach lining, it's all your skin, epithelial tissue. when you have like a blood vessel, we call these cells, this epithelial tissue, we call it endothelium. It's epithelium. Hold on, shut this. It's epithelial tissue. We just call it endothelium in a blood vessel. So it's a lining of the blood vessel. So I don't know if you've ever seen like when they when they're tearing down like businesses, like a building, and they break the cement, and then you see like those that rebar sticking out of the cement. That's kind of like what collagen is. So when there's damage to these epithelial cells, endothelium, the collagen fibers, it's like that rebar, and they stick out. And so the platelets that are going by, they notice that. That's like a signal for them. And they start coming over and sticking to that area. And then you notice like the first slide here and the second slide, they look different. Right here, they're like round. And here, they formed these projections. So they're going to form these projections to try to grab on. I don't know how this helps explain that, but they grab on to other ones. Let me do this again. Grab onto other ones. And so they grab onto other platelets, and then they're all sticky. So there's some chemicals. This is the part that I'd like you to know. There's some chemicals that are involved in this. So they, the first two chemicals are called ADP, and I've circled it here, thromboxane A2. Those are two chemicals that make the other platelets nearby sticky. So these platelets are like sticky, and they're grabbing onto other platelets. So they're changing their behavior. They're not just flowing together inside the blood. They start to release, like these platelets down here at the bottom, they're releasing ADP and they're releasing thromboxane A2. And that's making them sticky, which is in turn making the second row sticky, which is in turn making the third row sticky. And they're going to start grabbing on to whatever other platelets float by. So ADP is the, I don't know if you remember from like biology 1, that whole thing about ADP plus P equals ATP. It's that ADP. So ADP and thromboxane E2 make other platelets sticky, or as I wrote here, activate other platelets. Thromboxane A2 has another job. Besides being sticky, thromboxane A2 is a vasoconstrictor. So whatever the way the blood's flowing, you want to constrict the blood vessel before the leak. So like here's the leak, and the blood's flowing from left to right. You want to constrict it before the leak. I mean, it makes sense, right? To slow down blood flow. Right, so
we can use TH for short for this. We don't have to write it.
That's that. Fine.
Thank you.
You should know, like you should, the word thrombo, you should know what that word means whenever you see thrombo in another word. It's going to have something to do with clotting or platelets. Something to do with stopping blood loss, right? So just remember that word thrombo, because it's in lots of words. You're going to come across lots of like diseases and things that have this word with it. Yeah, so besides thromboxane A2, serotonin acts as a vasoconstrictor. You might know serotonin as some other function, and you're right. These chemicals, a lot of chemicals in our body do lots of things. Serotonin is that it helps you sleep. It helps as an appetite suppressant. It helps to balance your mood, to like make you not depressed. But here it's a vasoconstrictor, and it does more things. So these chemicals in our body, just remember they have more than one job. So it's not abnormal to see something like serotonin here, but you already know it as something that helps with your mood, right? It does both. So serotonin is a neurotransmitter. So I don't know if you guys even, all right, forget about it. So that's a platelet plug, right? It just, in short, to summarize it really short, the platelets see the collagen fibers, they all start sticking together, they plug up the hole. That's it. That's what happens, right? That happens within a few minutes, right? If you ever cut your finger or something like that, right? The blood stops. You don't bleed out. Unless you're taking a blood thinner, like Coumadin or whatever the other one, heparin, right? Those are going to decrease the amount of platelets you have. So that's why those people, if you prick their finger to get like a blood glucose or something, they're going to bleed more than they should because they don't have as many platelets, right? But that's a whole different problem. You've got this blood vessel and imagine half of this is blocked with plaque, right? So you've got a thin place to squeeze through. Imagine a residential street and you've got cars. Don't you hate when cars park on the street on both sides and you've only got that one narrow space to get in, right? So it could, if another car is coming the other way, it's going to get, you're going to have to slow it down anyway. That's why why you want to make the platelets less in that case, because someone's got plaque built up and your arteries are blocked, and so you don't want platelets. You don't want to take the chance that your platelets are going to start clotting up like this. But anyway, different topic. All right, so there's a platelet. Look, that's a clot. That's a thread. That's not a clot. It's the thread that's going to make a clot. So we call these threads fibrin. So one of your plasma proteins, if you remember, fibrinogen, or you'll hear me say it fibrinogen, but it's the same thing, right? Fibrinogen. That's a thread. So those threads make a net, and that net catches red blood cells, white blood cells, platelets, whatever. It catches all that stuff and makes a big ball, a big mass, an embolus, right? It makes a big embolus that is going to clot your blood. You want to slow like all your blood down, right? But when you do that, it's a serious matter. What I did here, what I should not have done here, is that I X'd out all of these tissue factors, which are actually quite important. I don't know why I X'd them out, because a lot of the drugs inactivate these tissue factors, factor 10, factor 7, whatever, right? So I'm not going to make you learn them for this class, but if you have like pharmacology or something, don't be surprised if you have to relearn it. But for some reason, I blocked it out here, so I'm just going to keep it blocked out. I don't care. But whatever the tissue factors are, what matters is that it ends up producing an enzyme called prothrombinase. I've actually written this on the next slide. In fact, we'll just, doesn't really matter where I put it, do I? Bam. You end up with an enzyme called prothrombinase, and as I have it written here, it converts something called prothrombin to thrombin. You have prothrombin in your body right now. It's fine. It's harmless, right? But when you need to form a clot, prothrombinase is going to be formed, is going to be made, and it's going to convert prothrombin into thrombin. So when you see pro behind this word, it means it's an inactive form. Just like if you look here, we have fibrinogen and then you have fibrin. The OGEN means inactive. Fibrinogen is an inactive form of fibrin. But there's another way to say something's inactive. So one way is that you have OGEN at the end, or the other way is that you put PRO before it. I don't know why the rhyme or reason to doing either one, but that's what it is. So if you see a word starting with pro, it's usually some kind of like precursor or inactive form. Right? So here, prothrombin is a precursor, or it's like the inactive form, and to activate it, I just take off the pro. So you think you're learning two words here, it's only one word. In fact, it's only this word, prothrombinase. Once you know that long word, take off the ASE for the next word. Take off the pro for the next word. So prothrombinase is an enzyme. We know it's an enzyme because it ends with ASE. And it's going to convert prothrombin to thrombin. Thrombin's going to turn around and activate the fibrinogen that's in your plasma protein. That's one of your plasma proteins. So you've got two conversions, right? The first bullet point is a conversion. The second bullet point is like another conversion. Kind of a waste of time. You're doing two conversions, but throwing a clot is not something you want to play around with, right? There better be something wrong with you, like you're going to die from bleeding out, because you're creating other problems. Where's that clot going to go? What if it goes into your lungs, into like the little capillaries of your lungs? You're screwed. What if it goes up to your brain and plugs up little capillaries in your brain? Again, you're screwed. You're going to stroke out, or you're going to get something called like a PE. But yeah, so it's not. What if it sticks in your heart? You know, so like in the, well, anyway. Point is, throwing clots, like making clots, better be something serious. And that's why you see all these conversions, right? If you look back at this, there's actually a bunch of conversions. You're making a conversion here, you're making another conversion, third, fourth. There's a process because you want to make sure that you don't have any false starts, that you don't do something when you don't need to do it. And your body has a lot, it's set up that way a lot, with a lot of different things. If your body's going to do something very serious, better make sure it's like correct. You see here I wrote plasmin dissolves fibrin. So those fibrin threads, the clot is hard to break up, right? In the hospital setting, we give it, you would give someone like they call it like a fibrinolytic agent, and that's usually something related to plasmin. So, yeah. So that's clotting. So you have platelet plugs, or if it's more serious, that's kind of the way I look at it. If it's more serious, you escalate to making a clot. So there's three defenses you have against bleeding out. The first one is called a vascular spasm. You can like contract all the muscle of you can contract the muscle of your blood vessels, right? Because your blood vessels are aligned with muscle, at least most of them are. Like your arteries, they have muscle in the lining. So you can contract that muscle. Like if my arm got cut off, like it only works if it's like a clean cut, right? So if I had like a clean cut, the arteries would retract into my arm and they would constrict, and you really wouldn't have a lot of blood loss, not like you think. Like you think it would be spurting out and stuff. That happens if something like rips the arm off. I know it sounds like gross, right? But usually when you have like clean cuts, there's not actually a lot of blood loss. So, I mean, same thing with a finger. When the finger comes off like really clean, there's not blood spurting out of it like on TV. Because of this, the vascular spasm. I didn't even talk about it. So I just talked about the second one and the third one. The second one being the platelet plug, and then the third being this slide that you're looking at, coagulation. So those are, clotting. Coagulation is clotting. Those are the three ways. Your blood, if it slows down, it'll kind of gel up on its own. Plasma gels up on its own. If you ever see the stuff like when they take blood in the vials, I mean, you guys probably know better than me, but some of them have like heparin at the bottom to keep it from clotting up. That's part of the thing with like, you heard of like deep vein thrombosis, and like if you're sitting on an airplane for a long time, it's because circulation in your veins is already, like the pressure is already really low. So it's already hard to get that blood from your feet back up to your heart. It's already difficult, right? And now you're sitting, like you're sitting on an airplane. You have, you're in bad health. You're old like me, and you have shitty circulation, and it's gonna stop. It's gonna slow down, and then it'll clot up. And then when it gets moving again, it makes its way up to your heart. The veins in your legs come back to your heart. That's where they're headed, and then your heart gets that blood clot, and it sends it up to your brain. Then you could, once it gets in your brain, it's going to smaller and smaller blood vessels, and maybe it'll stick in your brain somewhere and then give you like a stroke. All right, I'm getting way off topic. This slide, that slide. I don't care about number 1, 2, 3. I do care about the chemicals. ADP, thromboxane A2, abbreviated, and wusses, and serotonin. Those three chemicals. Right, I'm looking for that in the answer, right? But then you should also know that, the platelets all get together and plug up the hole. I got two more things on this chapter in blood, and they both have to do with blood type. Does anyone have any questions up to this point? I keep checking my phone to see if any of you are texting me, because like in case my internet goes out. So that's why you see me looking off screen. Unlike you're all on your phones, but you got your camera off. You're just like, you're not even, some of you are not even in the room.
Yes, we are. Yes, we are.
I know you're there. Some of you got a whole job. You're working your job.
I want you to see how I look. I look a mess, so that's on my camera.
You're all
I'm on my MacBook, but people keep walking by, so that's why I got the camera off.
No, sorry. I'm always working with you guys. The best feeling is when one of the great feelings for me is like when I have to have a meeting and I'll like zoom in on my phone, but like I turn everything off and I'm in another meeting, like a meeting that I have to be in person. So I'm like two simultaneous meetings and I just have my volume turned off. And when both of those meetings end, I feel so good.
Two birds with one stone.
Yeah, I got away with it. It's like, that was so efficient. I'm not going to listen to either meeting. So what does it matter? I could do both of them at the same time. I'm not listening to either. I can have a third meeting. Yeah, it's a great feeling. So your cells, all your cells in your body, they have like these little markers on them that say that they belong to you, except your blood. Every other cell in your body has these proteins that sit on the surface of the cell, and they're called like MHC. We'll talk about those in another chapter. But your blood cells are different from other cells, right? They're not even technically cells. They don't have a nucleus and stuff like that. We talked about that. They have to be made all the time, and they live for a while, and then they die. So they're different than our other cells. Our other cells will divide and divide and divide. Red blood cells don't. They're also different in the protein that sits on the surface. They don't have something saying like, this cell belongs to Klaus, and any other cell gets attacked. They have either A or B, or they don't have any, or they could have both, right? That's how they go. So there's really only two antigens. There's an A antigen and a B antigen. And then you could have different combinations, as you see here. So I could have the A, or my blood cells could have the B, or I could have both on them. So we call that AB. Or I could have none whatsoever. So, thank you. That was delayed. So what's the point? Okay, when you have none, just remember, like, your immune system attacks things that are different from it. I always picture it as having, like, every cell that's in your body has like a name tag here, right? And so if you have a name tag with somebody else's name on it, your body is going to attack it. If you don't have a name tag at all, you come without a name tag, that's okay, because you don't have a name tag with someone else's name, right? It's not like, oh, somebody else came. It's like, I can't even see there's a name tag, so that must not be anybody, right? And that's kind of like what type O is. So you don't have a name tag, that's fine. Your body is not going to see that as being foreign, as being something that doesn't belong. It's only when you have the protein that doesn't belong there. So if you're type A and somebody shows up with a type B antigen, you're going to kill it. It doesn't belong there. Same thing here. If you have type A and type AB shows up, well, the A's fine. I recognize the A. That name tag says Klaus. But then type B, that says Stu. Who the hell's Stu? Well, you got two name tags. Dead. But let's go the other way. You have both name tags on, Klaus and Stu, and then these two show up. It's fine. Type A, I recognize that. Type B, I recognize that. So you're good. Type O, it doesn't even have anything. So it's whatever. I know it's not foreign. It's not like another name. So that's why I wrote here, universal recipient. So type AB can get blood from type A, type B, type O. It doesn't matter. Type O is like the worst one to be in a car accident, because type O can't get blood from anybody but type O. Because anything with an antigen on is going to look strange, right? So it's only going to accept blood that doesn't have like no antigen on it. So that's kind of how that works. But we have to add something on top of that. You have to add, I don't have it as a slide, but you have to add the RH factor. RH. So if you have the RH, you're positive, and if you don't have the RH, you're negative. So, so you have two different things. You have like the blood type, the antigen, the A and the B antigen, and then you have the RH. So there's two different things. So to add to this, you have type A, type B, but there's also type A positive and type A negative. Type B positive, B negative, right? All of these have a positive and a negative version. If you are RH negative, you can always donate blood to a positive, but it doesn't work the other way around. All right, so negative can donate to positive, positive cannot donate to negative. Because again, you're introducing something foreign. So if you look at type O negative has no proteins on it. No antigens. There's no A, there's no B, and there's no RH. So that's the real universal donor. There's nothing on it. Whoever you give blood to, if you're O negative, whoever you give blood to is fine. The worst one as far as donating blood would be like AB positive, because they have everything on it. They have the A, they have the B, and they have the RH. but they're the universal recipient, right? They can get blood from anybody, no matter what you give, no matter who gives blood to an AB positive. Nothing's going to be nothing's going to be foreign. It's nothing they haven't seen before. So that's how that works. Now, this is like one example, one disorder or one situation that kind of exemplifies this, and that is called hemolytic disease of the newborn. So what happens is that the mother's RH, and this is not about the A and the B, this is about the RH. Mother's negative, father's positive. That means that there's a chance that the baby's going to be positive. So now you have a negative blood type, your baby has a positive blood type. The first pregnancy will be okay because there's a barrier there. But when the baby, when you're giving birth, then you're negative, you're going to get exposed to that baby's blood. So there you have exposure. During the first time you're giving birth, you're exposed to that Rh positive blood. So now you're going to start developing antibodies. Right, the second baby, then the mother will go after it. Because now the antibodies are there, and the antibodies will go after the second fetus. But now they give, they very routinely give, what medicine do they give for that? RhoGAM. Hey, sorry, what's Epigen?
Yeah, that's fine. That's just
Yeah. What's the other thing? Procrit?
yeah, there's a few of them.
Procrit.
There's a few brand names.
And tell me to stop bothering him with that questions. So I'd like you to be able to explain, what's going on here. And in this particular lecture, that's the last slide. I mean, I'm going to move on to the heart, but I mean, for blood, that's it. So does anyone have any questions? You guys want to take a break? Let's take a break for a few minutes.
I have a quick question.
Yeah.
Will this PowerPoint be posted somewhere?
It will. I think, yeah, it will. Because I'm going to add some, yeah. Right now, I only have one thing on the blood, right? I think it was this one. But yeah, I'm going to add the rest of it to it today. Anything else? Let's take a break for a few minutes. So I'm actually going to stop recording this lecture, and then in a few minutes, I'll start recording the next one. I'm going to mute myself for a few minutes. If I can figure out how to do it. All right, I'm back. We should probably talk about the test for Thursday before we go on. So, let me go to the class website. Oh, am I still recording it?